Your questions will remain anonymous. And then for the best viewing experience, we recommend closing any programs or browser sessions running in the background that could cause.
Well, that was a nice introduction. Hello, everyone. It's my honor to be putting on this talk. It's meant to be, pretty informal, and I will go through basically treatment of arthritis non-surgically, and I will touch a little bit on surgery.
Any interruptions or issues to the presentation. So now I'd like to hand it over to Dr. Zabilski to get going on his presentation on hip and knee arthritis.
Well, thank you, Jill, and the type of things that would cause us to do or recommend surgery briefly at the end. And so I'd like to just get started. So just as a little introduction here, just a little bit about me. I was undergrad at Boston College. I actually grew up in the Boston area in a town called Westwood, which some of you may be familiar with. I went to BC as an undergrad. I actually played on their football team. Went to medical school at Tufts University, graduated there in 1980, then went to Chicago for 2 years doing a general surgery residency, and then came back to Boston to do orthopedics at New England Medical Center. And subsequent to that, I did a sports fellowship at Children's Hospital in Boston and in New England Baptist. Currently, I'm the chief of the Division of Orthopedics at Beth Israel Deaconess Plymouth, past medical staff president and team physician for the U.S. figure skating team, or one of many, and was lucky enough to be the team physician at the 2010 Winter Olympics for the U.S. figure skating team. I have great partners in the practice. These are the rest of the doctors in the Plymouth Bay Orthopedic Group: Dr. Oliver, Dr. Stanwood, Dr. Reitmeyer, Dr. Keniston, who does our hand surgery, Dr. Leckie and Dr. Beck, who are our spine surgeons, and Dr. Turan and Abraham, who are our physiatrists. They do a lot of non-surgical back treatments, as well as pain medicine, and specialize in injections for pain control. We're affiliated with the Beth Israel Deaconess Hospital in Plymouth. Beautiful view in the summertime. So what I was planning on doing is, after the introductions, just talk about some arthritis facts, what we do when we diagnose arthritis, kind of show you what it may look like, and then the non-surgical treatment, and I'll briefly touch on some surgery. And then cover just a few newer advancements in technology and where hopefully things are heading in the future. And I'd be happy to take any questions you have. And Jill will be monitoring that on the chat section. So with apologies to David Letterman, joint pain, we see a lot of that obviously in my practice. And this is the top things we see. And as you can see, in the top three, knee and hip are right up there with shoulder. So you can see why I picked knee and hip as one of the topics for the discussion today. And with further apologies to David Letterman, these are the reasons we tend to see joint complaints. The first three is usually something related to trauma, and it could occur in any age population. The fourth one down, the first non-traumatic reason we see joint pain typically is arthritis. So you can see where it sort of fits into the structure of the types of things we're seeing. So what is arthritis? It's basically inflammation of a joint, and this could be acute, where it happens very suddenly, or it can be chronic and ongoing. Arthritis has the great distinction of the highest rate of all disabilities in healthcare amongst US adults. As the baby boomer generation ages, we expect this is to grow and surpass 60 million adults. The disease is physical. It affects a physical joint, but it also takes other tolls: mental, emotional stress, and economic tolls. If you're out of work, if you can't function, you can't sort of bring home the bacon, so to speak, it can certainly have other effects other than just pain. Worldwide, 350 million plus are affected, about 1 out of every 4 adults in their lifetime. This incidence is actually increasing because the population is aging as we get healthier and live longer over time. More than half of the adults are under 65 years of age, which is very interesting. And arthritis discriminates. It's not a fair with respect to the sexes. Women having 60% of the arthritis, where men is more 40%. The causes can be variable, and I'll touch on that in a few minutes. But most people over the age of 60 have some degree of arthritis, sadly, of which I'm one of those populations. Anyway, this shows how arthritis fits into the disability profile. It's number one. Back problems are number two. And actually, many back problems are due to arthritis or degeneration of discs. So if you lump those two together, you can see they're far and away the highest category of disabilities. The types of arthritis, the most common is osteoarthritis. Well, what's osteoarthritis? Osteoarthritis is the wear and tear arthritis. It's the tires going bald on your car after all this time. That's why it tends to favor the older population. In addition, rheumatoid arthritis, that's what we call an inflammatory type of arthritis. That's where your body can actually attack your own joints. Rheumatoid arthritis is one of them. There's a couple of different other types of arthritis that fit in that category. Gout is a third arthritis, and that is it's a reaction of your immune system to uric acid crystals in the joint, where the immune system attacks the joint. It causes inflammation and can actually cause joint damage with chronic gout over time. In addition, there's other lesser ones, ankylosing spondylitis. That's also an autoimmune type of a situation, again, where your immune system is kind of attacking your body. Juvenile arthritis, arthritis associated with psoriasis, and arthritis associated with lupus. So these lesser ones, making up probably about 30% or so, tend to be more inflammatory, where about 70% or so is more the wear and tear or osteoarthritis. We can control arthritis sometimes, but there are some factors that we cannot control. Age, our genetics, what we inherited from our parents. I can't tell you how many times someone would come in that has arthritis and say a hip or a knee, and they'll tell me that, you know, both their brother and sister had knee replacements or had arthritis. Their parents had it too. No one knows exactly how that works out, but we all inherit our characteristics from our parents, and that would include the strength of our cartilage, the kind of chemical makeup of our cartilage. It's all very similar, but there are very minor differences with genetics, and it can cause arthritis to form, the cartilage to wear out sooner or later. Congenital factors, some children are born with what's called hip dysplasia, where the socket does not form fully, and those people are actually more prone to things like developing hip arthritis later in life. Trauma, if you have a fracture around a joint, that can lead to destruction of the joint and wear and tear. That leads to what we call post-traumatic arthritis, which is very similar to osteoarthritis. Infections also, the infection process can cause an immune response that can attack the infection, but can also attack the joint itself, including the cartilage, and can cause that to dissolve and wear out quicker. Other illnesses, there's a condition known as avascular necrosis, where the blood supply to the bone can be affected, and that can cause the bones to soften and collapse and lead to arthritis as well. Controllable risk factors are activities. When I was a resident at the VA, we would see a lot of gentlemen that would have knee arthritis, and when we talk to them, they say, well, I was in the airborne and I'd be jumping out of airplanes all the time. And certainly that pounding type activities, especially over a long period of time, can have an effect. Someone's fitness level or their flexibility can certainly have an effect on whether or not the joint is going to be painful or not. The weight people are carrying will also have a big effect. The more pressure there is in the joint, the faster it's going to wear out. You can imagine if you take a pencil and lightly color with a pencil, it'll last a while. If you bear down really hard, it's going to wear out faster. And the same thing happens with joints. Someone's diet, and I'll touch on that a little later. There are certain things that can cause more inflammation in your body than others. Smoking is a big one also. Smoking impedes blood flow to your body, especially the very tiny blood vessels that go to the joints and the capillaries. That can choke off some of the nutrition that goes to the joints and other tissues for that matter, and can lead to early degeneration and wear. Other habits as well, other than smoking, things like vaping could also potentially cause a situation, or just sort of, quote, bad behavior for your joints. And there's a whole laundry list of that type of thing. So where does arthritis affect as far as age is concerned? This shows that basically the older you get, the more you get for arthritis. The 65 and older group has the highest degree of that, close to 60%. 45 to 65, about 40% or so of those people can have arthritis. And as you get down under 40, you can see that the incidence drops way off. So what does arthritis look like? To understand for a hip and a knee, I just wanted to give you a quick primer on what a normal knee joint would look like. Oh, I'm skipped ahead there. So on the left here is what a normal knee joint looks like. The yellowish is the bone here. This whiter area, that's called articular cartilage. That's what provides the smooth surfaces that the joints move against. The articular cartilage does not have nerve endings, so it tends to be relatively pain-free when those joints move against each other. There's 4 major ligaments around the knee. There's ones on either side called the collateral ligaments, and there's the cruciate ligaments in the middle. They cross each other. That's why they're called cruciates, and those all combine to perform stability for the knee joint. In addition, you've got a meniscus, which is these rims of tissue that go around either side of the joint. When those are damaged, that can cause rough areas that can wear on the articular cartilage and can lead to arthritis at an earlier age. They also tend to act like little shock absorbers in the knee. So as those are damaged, then the shock absorption is not as good. On the right-hand side is what an arthritic knee might look like. You can see where there's wear for the articular cartilage, where the bone is kind of showing through. That's what we call bone on bone. The bone does have nerve endings, and if you have bone scraping against bone, that can be very painful. If you have damage to these ligaments, that can cause the knee to move less effectively and can make it move, for lack of a better term, more sloppily, so that the knee joint, as it moves irregularly, can cause increased wear and tear over time. So this is what an x-ray would look like on the left here. Look, this is what a normal knee would look like. You can see there's spaces between the bones. That's because there's cartilage there. The cartilage doesn't show up on x-ray, so it looks like a space in the bone. On the right-hand side, you can see where there's a lot of arthritis in this area. You can tell because there's no cartilage there. The bones are touching each other. On this other side, there is a cartilage space there, but it's on this inner side of the knee here where the arthritis is the worst. You can see the bone looks whiter in this area. That's a response to the arthritis, what we call sclerosis. And sometimes you can get some bone cysts, which I'll show in the hip, and also bone spurs can form, which is very common and one of the hallmarks of arthritis on x-rays. So this is what a hip would look like. Again, you've got this smooth articular cartilage. You know, the hip is a ball that fits into a socket. So that cartilage is nice and smooth, and it moves very freely within the joint. Around that hip joint, there's a rim of tissue called the labrum. Sometimes that can be damaged with certain sports activities and can lead to joint pain as well, and over time can lead to arthritis. An arthritic joint might look something like on the right. On the left here, this is a cross-section of a hip joint. You can see the nice smooth cartilage here. The surfaces match each other. And on the side here, you can see some of the ligaments. On the right-hand side, this is an arthritic hip. The cartilage is worn away. The surface is rougher here. The red is supposed to indicate inflammation in that area and pain, and that certainly is what happens. Sometimes you can get to the point where the bone will wear against the bone and will flatten out. So instead of a ball, this can look like a mushroom. And then you've got mismatch between the socket and the ball, which even further leads to wear and tear. So this is an x-ray of a hip. On the left, it's a normal hip joint. You can see a nice space in here, what we call the articular space. On the right, that's gone. There's flattening of this femoral head. You can see these little holes in the bone. These are what we call degenerative cysts That's a response to the inflammation, and the bone is very white in this area. That's that sclerosis. It's a reaction of your body to the increased stresses on the joint. So the symptoms of arthritis, pain is the most common. And when we talk to someone about that, we want to know when it came on. Has it been a week? Has it been a month? Has it been a year? The location of the pain. It's important in both hip and knee. In the hip, it's important if it's in the front, in the back, on the side. The timing of the pain. When do you get it? The quality. Is it sharp? Is it dull? What makes it better? What makes it worse? Effective weight bearing, range of motion, maybe walking on stairs, whether or not medications help, and other associated symptoms. Do you have numbness or tingling? Does the pain radiate down the leg? Is there associated swelling, that sort of thing? Other things we look for is history of swelling. You can see on the left here, this knee is very swollen. There's very little distinguishing features. On the right, this is a normal looking knee. You can see the kneecap here. You can see a hollows around each side of the kneecap. You can actually see the kneecap tendon here. So this is what a normal knee would look like, and this is what a swollen, more inflamed knee would look like. The symptoms, stiffness is a hallmark of arthritis, and sometimes our joints feel kind of like this rusty hinge. It's tough to get going. It's a little creaky in the morning or when you first get up from a chair. It may take a few motions to get it kind of moving, and then as you get going, it tends to loosen up, almost like the Tin Man in The Wizard of Oz when he's stuck in the rainstorm and Dorothy has to put some oil in the joints there. Symptoms, crepiness. We've all experienced, well, hopefully not all of us, I guess, when our joints move, especially seems to be common in the knee that you might get a little clicking or popping, especially getting up from a chair or climbing stairs. That's because the joint is not perfectly smooth. I kind of liken it to the difference between driving down a cobblestone road here versus a nice, smooth superhighway. And with arthritis, you tend to get kind of that cobblestone look, unfortunately. Symptoms, a lot of people will have limping just because of pain if they put full weight on it. A lot of times people will limp when they don't even know they're limping. And the first they hear about it is when a friend or a spouse or whatever will tell them that, stop limping, you're always walking this way. And sometimes people are unaware of that. It happens sometimes so gradually that we don't even perceive that's happening. Deformity, this is something that's very common in knees, and it has to do with the degree of wear and where that wear is located. On the left here, you can see this person is very knock-kneed, and that's because a lot of the wear is taking place on the outer side of the knee. It's what we call valgus on this diagram up above on the right there, as opposed to knock-kneed or bow-leggedness. In that case, most of the wear is happening on the inner side, so you get the collapse on the inside and almost like a hinge effect on the outside here, and that can cause it. And it can be progressive, and sometimes it can be very severe. Generally speaking, men tend to get more of this type of arthritis. Women can also, but as a percentage, more women than men will have this arthritis where they're a little more knock-kneed as opposed to bow-leggedness. Leg length difference, that's something we'll oftentimes see in a hip, especially when it's very severely involved. And this can happen because of wear of that ball we showed you before with the flattening of that femoral head and the cartilage wearing away. That cartilage space is probably around, I would say, 4 to 5 millimeters in thickness, which doesn't sound like much, but then you add a couple of millimeters of wear of the bone, and sometimes you can have a 1/4 inch or even more in some cases. And then you can also, on top of that, have what we call apparent leg length difference, where the hip gets stiff, and it tends to be painful if you fully extend it. So people tend to walk with their hip slightly flexed, which causes a functional shortening as well. So a lot of times that limp we were talking about is not only a result of pain, but sometimes a result of leg length difference, both actual and the apparent or functional leg length. So how do we evaluate the joint pain? First of all, we want to get a good history. And sometimes if you just listen, people will tell you, usually the patients will tell you what's going on. And they do it in their own words, but they're usually very good about it. So just taking and listening for a careful history can be very beneficial. We talked about, how long it's been going on, what makes it better, what makes it worse. Is the pain located on the inner side of the knee or the outer side of the knee? Is it in the front of the hip and the groin or the back and the buttock? So that can be very helpful. Also, physical exam to determine exactly, where the pain is, how much swelling, how much the motion is present, whether or not there's any of that crepiness or popping or clicking or that sort of thing. Oftentimes people get x-rays, sometimes MRIs, and sometimes lab analysis. So this is an example of an exam of a deformity where the kneecap is kind of winding up on the side over here. It actually should be right in this area here. Obviously a very important piece of the puzzle. If someone shows up with arthritis under their kneecap later, we know it's what we call a post-traumatic arthritis. We check for range of motion, not only how much something can move, but also what happens when it's moving it. Is it painful? Where's the pain located when you move? Is there any clicking or popping involved? That sort of thing. Ligament examine. In this case, I'm trying to demonstrate how we would examine some ligaments to determine whether or not the knee is unstable. An unstable knee is certainly something that can lead to arthritis at an early age. And then sometimes we will do blood tests. Even if it doesn't seem like we need to, sometimes it's still a good idea because sometimes people can have two things going on. It's possible to have both osteoarthritis and rheumatoid arthritis, for instance, or you can have osteoarthritis and Lyme disease. So a lot of times we do want to check other things just to make sure that we're not focusing on just one thing that may be an incomplete picture or maybe even the wrong thing. Knee aspiration, that's where we take fluid out of the joint. That's really important if we're trying to diagnose something like gout. A perfect example of that is someone who was perfectly fine and then 2 days ago, all of a sudden had this intense pain, swelling, and inflammation in a joint. So this is sometimes very helpful, even actually sometimes even for things like Lyme disease. So in that case, some people have a very swollen knee joint, but may not be that painful. And you can tell just by taking fluid out and looking under the microscope and sending it for analysis. So the goals of treatment for arthritis, it's basically to control pain, preserve function or restore function, and to slow the progression of the disease. So non-surgical treatments, just briefly, and I'll go into these a little bit more detail. Medications, both orally and topically, activity modification, the old saying, doc, it hurts when I do this. Well, maybe you shouldn't be doing that. Heat or ice can be helpful, bracing, physical therapy or exercises, walking aids such as a cane or that sort of thing, and then injections. Medications, the mainstays are the NSAIDs and Tylenol. That's most commonly used. NSAIDs are called non-steroidal anti-inflammatory medications. Examples of that are aspirin, ibuprofen, naproxen. That would be things like Advil or Aleve. Advil is ibuprofen and Aleve is naproxen. Those are just over-the-counter doses as opposed to prescription doses. A lot of times we'll recommend trying to take this for a week or two, then taper down to take the lowest effective dose. These medications have two modes of action. They are pain relievers, like taking aspirin for a headache, but they're also anti-inflammatories. The trouble is the onset of action is different. The pain relief action usually occurs within an hour or a couple of hours of taking that medication. But the anti-inflammatory effect sometimes takes 3 to 5 days of being on that medication continuously at the recommended doses before you can get that effect. So sometimes saying, well, I took Advil once, it didn't help, that may not be enough for certain forms of arthritis. Sometimes you need to be on these for a while. And typically I'll tell people to go on them at a continuing dose regimen for about 5 to 7 days. And then if it's effective, then start tapering down to find out what's the lowest effective dose that will work for them. Tylenol can also be a very good adjunct, both either by itself or in addition to NSAIDs for pain relief. Tylenol is a pure pain reliever. It is not an anti-inflammatory. So you're not going to get relief of inflammation, but you might get relief of pain. A lot of people say, well, Tylenol doesn't work for me. Well, sometimes in addition, if you use it with another medication, you can get an additive effect. So maybe by itself it wouldn't work, but if you take it say between doses of Advil or Aleve, you may find it does help a little bit more. It may give you that extra 10 or 20 or 30% more relief that you're looking for. Prednisone is a form of cortisone. That is a steroid anti-inflammatory. It has very strong anti-inflammatory processes. That's different from steroids that someone would take, like an anabolic steroids for bodybuilding and stuff like that, which has kind of gotten a bad rap over the years. Prednisone is an anti-inflammatory that's used very frequently for a number of different types of inflammation, rheumatoid arthritis, also in inflammation in other areas of the body. Asthmatics, for instance, are oftentimes put on prednisone when having a flare-up. Anti-rheumatics, we see these advertised on TV all the time, and it's not just for arthritis, but other things like for skin disorders, that sort of thing. And they have very strong anti-inflammatory effects. A name for these are DMARDs, D-M-A-R-D-S. They're considered disease-modifying anti-rheumatics. And for people with rheumatoid arthritis and the inflammatory arthritis, these can be a godsend. In the past, people with rheumatoid arthritis would very frequently get very severe deformity of their joints, especially in the hands. These disease-modifying medications have made that degree of deformity very unusual, and actually has incredibly positively affected the lives of people with rheumatoid arthritis. And certainly if you have rheumatoid arthritis, it is good to talk to a rheumatologist about this, as you may or may not be a candidate for these types of medications. Other sort of adjunctive medications we'll use, sometimes muscle relaxers. Oftentimes when people have pain, they'll have muscle spasm associated with that. Antidepressants, and it's not that people get depressed, but certain antidepressants have been shown to actually be effective for chronic pain syndromes. Two other medications kind of in their own class, the gabapentin and Lyrica, they're used for more chronic pain and nerve type pain, but also occasionally can be used in some cases of arthritis pain, especially when other options may not be available. And then topical agents. We all remember old Bengay, Flexol with Joe Namath talking that, capsaicin. There's an anti-inflammatory cream, Voltaren gel, that's recently been released for over-the-counter use in the US. And other things, you could almost consider things like heat or ice as a medication. Heat has been shown to be as effective as some medications for the treatment of arthritis. Holistic supplements, herbs are very popular. There's about 30 different ones. I'll touch on a few. Other supplements, glucosamine and chondroitin sulfate. The science is sort of iffy if you look at double-blind studies, but anecdotally, a lot of people do very well with these. A lot of times I will recommend trying this. It'll cost you about $30 a month to find out. It takes being on these about a month or so to know if they're actually working. And sometimes you don't realize if they're working until you stop them and your pain gets worse. MSM is another naturally occurring anti-inflammatory, similar to glucosamine and chondroitin sulfate as far as how you take it and the way it works. Omega-3 fatty acids are also anti-inflammatories, but increases blood flow to the joints. A big one these days is the cannabis medications, and that's unfortunately has not been well studied yet. Anecdotally, the CBD, some people tell me it works, other people tell me it doesn't. Unfortunately, there's no really good studies to know whether CBD is that particularly helpful, though there's, as far as I've seen, there's very little harm to trying that, either the topical or the oral forms of that. In addition, there's other mind-body approaches. Acupuncture is a big one. It can be very helpful for eliminating or decreasing pain due to a number of different factors, arthritis being one of them. Biofeedback techniques, massage therapy, meditation, deep breathing, again, is a form of meditation. Tai Chi, for those unfamiliar, that's a Eastern type of exercise. low impact, very fluid motions, and can be helpful as far as maintaining joint strength and range of motion. Visualization, imagining your pain going away. Again, a form of meditation and a biofeedback. Yoga is great for maintaining joint strength. It's low impact on the body. Sometimes some of the positions are either impossible to get into, at least for myself, but sometimes can be painful. So you have to be somewhat mindful about what you're doing in yoga and the type of positions you're doing. Aromatherapy, spiritual healing. I've had a number of people tell me that with spiritual healing, they've done well, and that's more of a faith-based situation that some people do very well with. Magnets, that was something big, I would say probably 10 years ago. It's still there. Not much in the way of science as far as proving it works or not works, though again, anecdotally, some people will tell me. We all seen the copper bracelets is another thing. Again, very little data, but anecdotal testimony does seem to say it does work for some people. Foods, that's another thing. There are certain foods that are considered inflammatory foods, and that can be in your GI tract, but also can also relate to the joints. I've got a list, but this is probably a little better list here. White sugar, refined grains, and some of the cereals we buy, especially the ones that have lots of sugar on them. Trans fats, mostly fried foods. Other food additives, MSG is a big one. It does have pro-inflammatory qualities, at least for some people. Processed oils, these are the saturated oils, corn, soybean, canola, cottonseed, and safflower. Those can cause inflammation in your gut and in your system. Gluten is another thing that's present in most breads, unless you're buying gluten-free. It has to do with processed grains. Dairy can also be the type of, it's called casein, is one of the proteins in dairy that can be inflammatory. Soy also can be inflammatory. Alcohol, tough to hear in these days of COVID, but yes, that can affect your joints. And certain raised meats or beefs, the grass-fed seems to be maybe a little bit better than corn-fed or feedlot raised, and peanuts also can be inflammatory. And also a lot of people do have a certain amount of allergic response to that, which is part of the inflammatory process. Foods that are joint friendly, mainly the unprocessed foods, you could lump them into that category. The Mediterranean diet is certainly an example of that. It's not the only one. Fish is a good source of proteins that's not inflammatory. Whole seeds and nuts, fruits, vegetables, beans, whole grains, olive oil. So if you have to have oil, rather than safflower oil, then olive oil is a better one to have. And you need to be careful with your salad dressings, because a lot of the salad dressings will have some of those sort of unfriendly oils in them. Physical therapy, we touched on that earlier. The goal of that is to improve their strength and motion and flexibility. Oftentimes when someone is arthritic, they will tend to get atrophy from lack of use of a joint. Even if it's just favoring it a little bit over time, you can end up with weakness of the muscles, some stiffness sometimes, and lack of endurance. The idea behind the physical therapy is to normalize whatever you can as far as muscle function, strength and endurance, so that the joint functions as normally as possible. Bracing, light brace on the right, something called an unloader brace on the left. A lot of times these braces, the one on the left is called an unloader brace. This is meant, it has a hinge here, and this is used for people with arthritis where one side of the knee is worn out. We saw that example on that x-ray where that inner side of the knee was worn out and someone was more bow-legged. The idea behind this brace is it cranks the knee out of being bow-legged. So it shifts weight from the arthritic side to the more normal side. And sometimes that can help. The downside of this type of brace is it's worn fairly snugly. It can get uncomfortable over time. It's good for doing certain tasks, but it's not something you can wear comfortably all day long for the most part. The other braces, these lighter braces, these come in two different varieties. This is what they call a sleeve brace, where you just pull it on like a sock. There's other types of braces that wrap on with Velcro straps. I like the ones that wrap on better. Usually these types of braces come in 3 sizes, where knees come in about 1,000 different sizes. So with this, oftentimes the brace is going to be either too tight or too loose, and there may be mismatch between above the kneecap and below the kneecap. Whereas the ones you wrap on, you can snug them up here and down here sort of individually, and you can get more of a, quote, custom fit pretty much every time you put it on. Usually this doesn't show up, but usually I recommend using a type of brace that has a hole for the kneecap right here, where the kneecap kind of sticks out. That way you're not compressing the kneecap. In the case of kneecap arthritis, that can be important. Walking aids, and this can range anywhere from a cane actually to a wheelchair. Even before a cane, some people will sometimes use just like a hiking pole or a walking stick, something that doesn't have quite as much stigma attached to it. You know, we see people out with walking poles just hiking around and doing their trekking. Those trekking poles are fairly inexpensive, and they can be very helpful as far as unloading the joint a little bit. And not that it will make it so you can walk when you can't, but it may allow you to maybe go a little further. Obviously, as the arthritis gets worse, you're going to kind of go down this list here to crutches and maybe a walker, with or without wheels, and then finally, hopefully, no one has to get to a wheelchair. One of the treatments we oftentimes do is cortisone injections. Injections can be very helpful. There's 2 main types of injections that we use in the office here. One is cortisone. The cortisone is an anti-inflammatory, like we talked about earlier. And in that case, we inject right into the knee joint. And the idea behind that is we're putting the anti-inflammatory right into the knee. Occasionally, we can actually do that into the hip. That's something that we would usually refer to one of our physiatrists for, because when we inject into the hip, that has to be done under x-ray or at least under ultrasound guidance, which we don't have typically in the office here. But we do have a procedure room in our building here that can be done in. In addition to cortisone, and actually cortisone, just to elaborate a little more, the onset of action is usually relatively quick. It usually takes a day or 2 to start taking effect, but usually can take full effect within a week or 2. I usually recommend you give it a month or so just to see, but oftentimes people can get sometimes dramatic improvement. The duration of action is very variable. It can last anywhere from days to months. And that depends on the degree of arthritis, how bad it is, what your activity levels are, and that sort of thing. There's also a lubricating shot, or what we call viscosupplementation shots. Used to be called a rooster shot because it was some of the earlier versions of that was made with rooster combs that were processed. It's usually some type of a hyaluronic or hyaluronic acid derivative. And what it does is it tries to reproduce our normal lubricants sort of artificially. So it's very similar to the normal lubricants we'd have in our joints. It's a little bit thicker. And if anyone remembers STP oil treatment, we used to put in the cars when they were banging and clicking and stuff like that. It's a very thick oil, that STP oil treatment. That's kind of what this is. It's a very thick gel type injection, and it's supposed to allow the knee to be better lubricated. It creates what they call a boundary layer over the arthritic areas so that the 2 bones kind of skip over each other a little bit more and creates almost like an insulation against the bone, so you don't have maybe quite as much of that bone on bone. And that can cause the inflammation to decrease over time. The downside of this is a lot of insurances don't cover it. Oftentimes we need to get some what we call prior authorization before we can do it. And they're expensive. Some of these shots can be $1,000. And the efficacy is about 50-50. In other words, about half of people will get relief from it. And again, the relief that you get from it is variable, but can last sometimes as much as 6 months or so. But in some cases, it may last not at all, or a couple of weeks or a month or so. In addition, some of the newer technology out there is something called PRP, or platelet-rich plasma. That's actually a derivative of your blood, where they take blood from you, they put it in a centrifuge and spin it down, and then isolate this layer of these platelets and re-inject it. And theoretically, it can act almost like a stem cell, though it's not technically a stem cell, but can theoretically provide certain chemicals that allow for healing or increased healing. Unfortunately, there's no good studies that show that it really makes that much difference. And most of the studies, when it comes to injecting in joints, are inconclusive or maybe mildly beneficial. Stem cells is another thing that is intensely being studied. There's stem cells, for those who are not familiar with it, are what we call progenitor cells. They're very immature cells that can differentiate into a number of different things. If you inject it into a knee, it might differentiate into cartilage cells. If you inject it into a bone, it might turn into bone cells. If you inject it into muscle, it might turn into muscle cells. So they're very sort of primitive on the scale of differentiation or maturation of cells. And we all have these. They're in our bloodstream, they're in our bone marrow, and they're actually even in our fatty tissue. And there's been a number of different studies where they've taken different types of these cells and purified them and re-injected them. Unfortunately, with varying results, they've not come up with a particular mix or recipe, I guess, that provides uniform and predictable results. So now it is still investigational or experimental, both PRP and stem cells, and they're usually not covered by insurance, and they're very expensive, to the tune of thousands of dollars, sometimes tens of thousands of dollars. So it's not something I can recommend at this point, but something that we're watching very closely. If all those fail, sometimes we head to the OR. And I know we're not gonna, this talk is not about surgery, and I'm certainly not pushing that, but I think it's good to know when we look at that. First and foremost, we try non-surgical treatments, and we do surgery when there's a failure of the non-surgical treatments. They just don't work. The arthritis is just so bad, nothing's gonna work anymore. Usually your symptoms need to be limiting your activities of daily living. Other signs that you might need surgery: pain at rest or pain at night that wakes you up routinely. Stiffness of the joint to the point where it severely limits your movement. Even if the pain is not bad enough, sometimes the stiffness can be so bad that you just can't function anymore. I usually tell people it's time to consider surgery when you've gone through the treatment and the pain or the symptoms are at the point where it's stopping you from doing the things you want to be doing or the things you have to be doing. So things you really enjoy, your hobbies or your work activities that you really need to be doing. So just summarizing a little bit. So things to do: judicious use of medications. Generally speaking, take the lowest dose that works. The types of medications are important. Some people can take those NSAIDs. If you're on a blood thinner, you can't take them because NSAIDs do thin your blood. So the Advils and the Aleve and that sort of, and aspirins, if you're on blood thinners such as Coumadin or warfarin, Xarelto, Eliquis, those things, you should not be on those types of medications. So Tylenol and some of the others we talked about might be beneficial. Stay as active as you can comfortably be. Some people will say, well, you know, I used to be able to walk 3 miles, I can't do that. And I'll say, well, then walk 2 miles or walk 1 mile or walk 1 mile twice, or do what you can do, because that's still going to be beneficial. Substitute things you can do for things you can't. You can't ride a bike, but maybe you can do upper extremity kind of pedaling with so-called ergometers. You can lift weights with your upper body, maybe light weights, even though you may not be able to do it with your lower body, or you can do it with your lower body when you can't do it with your upper body. So those are the things to try to do what you can do as best you can. The old doc, it hurts when I do this. Well, then don't do it. Don't do it if it hurts, especially if it's very painful. Turn up the heat. Like I said, heat can sometimes be effective as pain medicine. Be careful you're not putting too much heat on there. You don't want to burn, create a first or second degree burn. Cool it. Icing can be very helpful. It's a good anti-inflammatory and it can help relieve pain, at least temporarily. If you're smoking, you may find that stop smoking does help with joint pain over time. It's not something that happens right away, but it's something that as your joints recover, it can be helpful. Wrap it up, use a brace, a light brace or a wrap, a ace wrap. Sometimes that can be very helpful. Lose that spare tire. A modest amount of weight loss can be very helpful. We all have these things on our wrist now that measure how many steps we take. And we're all, not all, but a number of us are taking thousands of steps a day. A relatively quiet day for a lot of people is 1,000 steps. So if someone lost 10 pounds at 1,000 steps a day, that's 10,000 pounds a day less that your joint sees. And you can see how that can add up over time. There's been some studies that show that if you lose a pound, that's equal to 3 or 4 pounds that your knee sees because of the way the mechanics of the joint works, the muscle pull, that sort of thing. And the same on the hip. So if you took that as gospel, then a 10-pound weight loss at 1,000 steps a day is 30 or 40,000 pounds a day less that your knee sees. So you can see where even sometimes a modest amount of weight loss can be very helpful. Eat healthy. Try to avoid the inflammatory foods as best you can. Warm up and stretch first before activities. Some people say, I hear a lot that when I get out of bed or get up from the chair, my knee's really stiff. It doesn't work well. It takes me a few steps to get going. Well, I think it's reasonable to sort of take those steps, quote unquote, before you get up. Move the knee like you were moving it, like you were walking before you get up and put weight on it. And sometimes that does get sort of the quote juices flowing, gets the lubrication in there. So those first couple of steps are not as bad. So when to seek medical attention, when to come and see me or one of my partners. If your joint pain is severe and unexplained, you just don't know where it's coming from, or if it's come on and getting worse very rapidly. If the pain is lasting more than 3 to 7 days. And again, a pain that's getting better over that time, I wouldn't worry so much about, but a pain that's the same or getting worse over that period of time is something to be concerned about. If you've got a hot, red, swollen joint, especially if you have fevers or chills associated with it, that could be a sign of infection. That's something that needs to be seen pretty much right away. If you're using medications and you're just not getting better, you're trying these things we talked about tonight on your own, it's just not getting better. That would be a reasonable time to get it checked out, get an x-ray, maybe an MRI, see what's going on. And if you've recently injured the joint, sometimes you can have a fracture or a break in the joint and not even realize it. Sometimes it does take an x-ray to show that. And sometimes you can have what we call these little hairline fractures or cracks. Or over time, you can develop what we call stress fractures, overuse type injuries that can cause pain over time. And that's something, if it isn't getting better, to get checked out. So thank you for spending time in this talk. If anyone has any questions, they can type them into the chat, and Jill will read them to me, and hopefully I can get to those.
Thank you, Dr. Zabilski. Like he said, so if you're on Zoom, you can type in a question in the Q&A portion on the bottom of your screen. And if you're on Facebook, if you have any questions, just type them in the comments section. So
we'll give this a minute or so and see. Maybe everyone's very knowledgeable and they have no questions, or maybe I did such a great job I answered them, but I doubt that's the case. So
we have a great job. Thank you. Oh, we have a question. How long does a typical hip replacement last?
That's a great question. Typically, a hip replacement, we can expect it to last around 15 to 20 years right now. The thing is, though, the ones that we're using now have not been out that long, and they may actually last longer. So we're hoping the technology has changed in some of the bearing surfaces that are used over the last 10 years. So we're hoping that actually these may last longer.
Great. I think that might be it, Dr. Zabilski.
Okay. Sounds good.
Thank you very much, and thank you everybody for joining us tonight. Again,
Thank
keep
you.
an eye out for all the we have speaker sessions every month, so keep an eye on our social media pages for when those are. So thank you, Dr. Zabilski.
Very welcome. And thank you everyone for attending. Have a great night and stay safe.